For the last year, I have been sending freedom of information requests to lots of trusts about their staffing models on antenatal and postnatal wards. The reason being, I want to collect the data to see what the midwife to bed ratios are, whether they class babies as patients, to be able to improve care for families. Staffing in maternity units is incredibly complicated and complex. It is not as easy as saying you need X amount of midwives and that's that. There will be some women and people who are incredibly high risk who need a lot of care. There will be some others who require very little support at all. This is in the context though that we have much more complexities around labour and birth. More women and people are having babies that never would have had babies 20 years ago, with cardiac problems, with previous deep vein thrombosis and pulmonary embolism and strokes and lots of other things. Lots of diabetics now coming through as well. But it is worth remembering that our induction of labour and our caesarean birth rate is increasing. Both of these significantly increase the amount of care hours that women need to be able to have safe care. And without increasing midwife numbers to actually provide that care, women's care hours are not met, women's care needs are not met, and so there needs to be a national mandate. I've written to my MPs on a number of bases. The previous Conservative MP was an absolute waste of time, quite frankly, every time I'd write to them. But my more recent one was really good and sent off all of my information to Baroness Merrin. And her response was actually really thorough and really good, and it highlights that it's up to local trusts to decide how many staff they do or don't have. What this means is, in practice, is some trusts can completely get away with having very few midwives, very few support workers, and they don't necessarily have to review their staffing levels that regularly. Some trusts are fantastic. Some have recognised that increasing induction of labours mean that we need to either start limiting or capping the amount of inductions that are ongoing, or we need to start providing more midwives and have caps of how many women a midwife can look after having an induction. Please tell me if 6 women that you are looking after as a midwife, and this is not the lowest amount of inductions that any trust can have, 8 to 10 was the highest, so 8 to 10 women going into labour is not a safe number to look after. But if you are looking after 6 women who all go into labour, because the intention of an induction is to go into labour, if you have 6 women go into labour, how can you provide adequate pain relief to them? How can you adequately listen to them? How can you adequately monitor all 6 babies at the same time as one midwife? And just for context, maternity support workers cannot provide monitoring to babies during an induction of labour process. They can't provide pain relief, so it has to come down to a midwife. Now, if you are one midwife looking after 4, 5, 6, 7, 8 induction of labours that are going to start labouring at some point, that's the intention. How do you safely meet the needs of those women? How do you safely provide the experience that those women need during labour and birth, that they adequately deserve? And this is quite a quick fix to actually start building trust with families, because if you said in your induction of labour, your midwife will only be looking after 3 or 4 of you at once, you will all be able to access that care as and when you need. You will be able to provide pain relief as soon as you require it. You'll be able to have one-to-one care. The moment you go into labour, you will be able to have a staff member provide care for you. You will not be waiting days waiting for a bed where there is a midwife available. Imagine if we could put that in place, the immediate trust that would start increasing in maternity services overall. We know that national recommendations really mean that trusts have to start sitting up and listening nationally to what's being recommended. And we have seen historically that this does work, but only mandating it in one place in maternity services puts the rest of maternity services at detriment. Because what happens is, in order to meet the needs of one-to-one care in labour wards, what happens is you have to start pulling people from wards, from birth centres, closing them, closing home birth services, for example. You have to start pulling community midwives in, which then impacts on the community services that women have in antenatal period. It impacts on antenatal education. It impacts on whether women can access their 34, 36, 38 week appointments, for example. And that has a huge impact then on maternity services in assessment units and triage units. We know that implementing it at national recommendation level increases workforce numbers, but it has to be across the floor. Maternity assessment units need minimum staffing ratios, they need acuity figures, so do triage units. And in wards, they need to start counting babies as a patient. It seems really, really simple, and I know it sounds simple. If you are in transitional care, there are minimum staffing ratios that are recommended nationally of 1 to 4. That's 1 nurse to every 4 babies that's recommended for babies who are on IV antibiotics born under 36 weeks. Babies are not counted as patients who are on 2-hourly observations, who are having extra care for feeding support, for blood sugar monitoring. Women are expected by every single trust to look after their baby. Now, please tell me how somebody who has just come out of theatre, having had a caesarean birth, gone to the ward within 2 to 3 hours, how someone who has still got their epidural, meaning that they can't be mobile, how they can reasonably provide care for their babies, because that is the expectation. Every single trust does not class babies that I have FOI'd as a patient who are not in transitional care. So those babies requiring observations, those babies requiring additional needs, they're not counted. It's a really simple fix that you start saying babies are patients, because suddenly overnight you'll have to double your workforce for postnatal midwives. And caseload numbers for community midwives needs exploring and looking at. Along with other factors, it's incredibly difficult because sometimes on paper you look like you're fully staffed, but you've also got to consider that you might be fully staffed with maternity leave, with sickness, with absence, for example. The average midwife, because of the pressures that they're under, has an average of 22 days of sick leave a year. And part of this is burnout related. It's also thinking that your immune system is weakened without breaks, without adequate rest times as well, which Leah Hazard's petition is so vital and so important to really look at. Because if you work for really long hours without breaks, you're being expected to cover on-call services. Actually, that does have a knock-on impact on your health and well-being. And what also has to be considered is the skill mix too. We need experienced midwives to stay. On average, around 700 midwives are leaving the NMC register every 6 months. I don't know very many midwives that have not got an exit plan from traditional NHS midwifery services, because they are exhausted, and they're exhausted of really saying, we are drowning here. Every single policy that you keep coming out to say that will improve care adds an extra 5 minutes, whether that's smoking cessation and monitoring, for example, whether that's additional observations for babies, whether that's additional reasons to observe women or babies, whether that's because we're now seeing huge increases in reduced fetal movements because we've got this brilliant campaign, but it means more women are coming in with reduced movements, but we've not got the staff to be able to do it. Whether that's because of Saving Babies' Lives recommending more inductions for certain things, but we still haven't got the staffing infrastructure to be able to provide that care. And in terms of experience to newly qualified, there are no recommendations as to the establishment that you should have. You could have on paper a fully staffed unit, but the majority of them are newly qualified. Well, newly qualifieds need support, they need nurturing, they need someone else to be able to support and buddy them sometimes. They are the ones who have to go and sit and read the guidelines far more intensely, because it's all still quite new to them. They are still learning new skills and they need and require that support. Staffing is the huge elephant in the room, and they've looked at retention, which is fine, but you cannot have retention without increasing your workforce numbers overall. We know that around 8 to 10% of all newly qualified midwives leave within that first year. 700 midwives a year are leaving the NMC register, really highlighting that what we need to start doing is start reducing the pressure and the expectations of midwives by reducing their workloads that are expected of them, ensuring that they get breaks as well. If you do not increase your workforce numbers, you cannot implement any other recommendations. You can't organise and sort out your culture. You can't have psychological safety, because if you're constantly running on empty and going, no, we can't do that, no, it's too busy, no, we've got to keep escalating, we've got to focus on phoning around other units, we've got to keep closing our unit, we've got to keep closing our home birth services. What you are doing is you are firefighting that entire time. It is complicated. What we can do is have real national frameworks, national recommendations of safe midwife to patient ratios in every single setting of maternity services, including community caseload numbers, and things will start changing for the better. There is a template in my bio. You can just copy and paste as a midwife or student midwife, send it off to your MP. It's so important that Baroness Amos starts really listening and amplifying our voices as midwives, so that we can really make a change collectively. This is the time. We need to work together collaboratively now. Women, people, families deserve far better, and so do we as midwives. And until we start looking after midwives, nothing's going to change.